Hello everybody, I am Dr. Armen Astvatsatryan, professor from Yerevan, Armenia. So for you I'm Dr. Y, and we continue to talk about COPD, chronic obstructive pulmonary disease. Let's talk about diagnosis. Okay, of course, diagnosis of COPD is based on chest X-ray and pulmonary function testing. Diagnosis is suggested by history, physical examination, and chest imaging findings, and is confirmed by pulmonary function test. Similar symptoms can be caused by asthma, heart failure, and bronchiectasis. COPD and asthma are sometimes easily confused and may overlap. Systemic disorders that may have a component of airflow limitation may suggest COPD. They include HIV infection, HIV, AIDS infection, HIV, abuse of intravenous drugs, particularly cocaine and amphetamines, sarcoidosis, Sjögren's syndrome, bronchiolitis obliterans, bronchiolitis obliterans,
lymphangioliomyomatosis,
and eosinophilic granuloma. COPD can be differentiated from interstitial lung disease by chest imaging, which shows increased interstitial markings in interstitial lung disease, and pulmonary function testing, which shows a restrictive ventilatory defect rather than an obstructive ventricular defect. In some patients, COPD and interstitial lung disease coexist, combined pulmonary fibrosis and emphysema, in which lung volumes are relatively preserved, but gas exchange is severely impaired. So about differential diagnosis. So diagnosis, for example, COPD. Onset, middle age. Imaging results, sometimes lung hyperinflation, bullae, increased retrosternal air space, and or bronchial wall thickening seen on chest X-ray. However, usually not helpful diagnostically and done mainly to exclude other disorders. Other features of COPD: slowly progressive symptoms, history of smoking or exposure to tobacco or any other types of smoke. Asthma, onset early in life, often during childhood. Imaging results, usually normal or possibly hyperinflation. Other features concerning asthma, symptoms vary widely from day to day. Symptoms often worse at night or early morning. History of allergies, rhinitis,
rhinitis,
or eczema. Often family history of asthma, often obesity. Bronchiectasis, all ages onset, but most often in older or middle age. Imaging results, bronchial dilation and bronchial wall thickening seen on chest X-ray or chest computed tomography. Other features, often large amounts of purulent sputum, often history of chronic recurrent bacterial infection. Another diagnosis, diffuse panbronchiolitis. Onset usually between ages 10 and 60 years, mean age of 40. Imaging results, centriolobular nodular opacities and hyperinflation seen on chest X-ray and high-resolution computed tomography. Other features, mostly male non-smokers. Almost all have chronic sinusitis, predominantly in those of Asian descent. Heart failure, ages of heart failure, all ages but most often in older or middle age. Imaging result: enlarged heart, pleural effusion, fluid in major fissure, sometimes pulmonary edema seen on chest X-ray, and chronic heart failure, of course. Other features: volume restriction without airflow limitation, detected by pulmonary function tests. Obliterative bronchiolitis, onset at younger age. Imaging results: hyperdense areas seen on computer tomography during expiration. Other features: non-smokers who may have a history of rheumatoid arthritis or acute fume exposure, history of lung or bone marrow transplantation. Tuberculosis, onset all ages, lung infiltrates, typically multinodular, sometimes calcified hilary nodes seen on chest X-ray. Other features confirmed by microbiologic testing, usually in areas with high prevalence of tuberculosis. About pulmonary function tests. Pulmonary function test. Okay, let's talk about pulmonary function tests. Patients suspected of having COPD should undergo pulmonary function testing to confirm airflow limitation, to quantify its severity and reversibility, and to distinguish COPD from other disorders. Pulmonary function testing is also useful for following disease progression and monitoring response to treatment. The primary diagnostic tests are FEV1, FEV1, the volume of air forcefully expired during the first second after taking full breath, forced vital capacity, FEVC. So the total volume of air expired with maximal force, flow volume loops, simultaneous spirometric recordings of airflow and volume during forced maximal expiration and inspiration, reduction of FEV1, FEVC, and the ratio FEV1, FEVC are the hallmark of what? Hallmark of feature. Yeah. Of airflow in limitation. Flow volume loops show a concave pattern in the expiratory tracing. There are two basic pathways to which COPD can develop and manifest with symptoms in later life. In the first pathway, patients may have normal lung function in early adulthood, which is followed by an increased decline in FEV1, about more than 60 milliliter a year. With the second pathway, patients have impaired lung function in early adulthood, often associated with asthma or other childhood respiratory disease. In these patients, COPD may present with a normal age-related decline in FEV1, about 30 milliliter a year. Although this second pathway model is conceptually helpful, a wide range of individual trajectories is possible. When the FEV1 falls below about 1 liter, patients develop dyspnea during activities of daily living. Although dyspnea is more closely related to the degree of dynamic hyperinflation, progressive hyperinflation due to incomplete evaluation than to the degree of airflow limitation. When the FEV1 falls below about 0.8 liter, patients are at risk of hypoxemia, hypercapnia, and cor pulmonale. FEV1 and FEVC are easily measured with office spirometry. Normal reference values are determined by patient age, sex, and height. Airflow limitations severely in patients with COPD and FEV1-FEVC ratio less than 0.70 can be classified based on post-bronchodilator FEV1. Mild, more than 80% of predicted; moderate, 50 to 79% of predicted; severe, 30 to 49% of predicted; very severe, less than 30% of predicted. Additional pulmonary function testing is necessary only in specific circumstances, such as before lung volume reduction procedures. Other test abnormalities may include increased total lung capacity, increased functional residual capacity, increased residual volume, decreased vital capacity, decreased single breath diffusing capacity for carbon monoxide, DLCO, findings of increased total lung capacity, functional residual capacity, and residual volume can help distinguish COPD from restrictive pulmonary disease, in which these measures are diminished. Decreased DLCO is non-specific and is reduced in other disorders that affect the pulmonary vascular bed, such as interstitial lung disease, but can help distinguish emphysema from asthma, in which DLCO is normal or elevated. Imaging tests. Chest X-ray may have characteristic findings. In patients with emphysema, changes can include lung hyperinflation manifested as flat diaphragm, that is, increase in angle formed by the sternum and anterior diaphragm or lateral film from the normal value of 45 to 90 or to more than 90 degree, rapid tapering of hilar vessels and bullae, that is, radiolucence is more than 1 cm, surrounded by accurate hairline shadows. Other typical findings include enlargement of the retrosternal airspace and the narrow cardiac shadow. Emphysematous changing occurring predominantly in the lung bases suggest alpha-1 antitrypsin deficiency.
Alpha-1 antitrypsin deficiency.
The lungs may look normal or have increased lucency secondary to loss of parenchyma. Among patients with chronic obstructive bronchitis, chest X-rays may be normal or may show a basilar increase in bronchovascular marking as a result of bronchial wall thickening. Chronic obstructive bronchitis. Prominent hilars suggest large central pulmonary arteries that may signify pulmonary hypertension. Right ventricular enlargement that occurs in cor pulmonale may be masked by lung hyperinflation or may manifest as encroachment of the heart shadow on the retrosternal space or by widening of transverse cardiac shadow in comparison with previous chest X-rays. Chest computer tomography may reveal abnormalities that are not apparent on the chest X-ray and may also suggest coexisting of complicating disorders such as pneumonia, pneumoconiosis, or lung cancer. Computer tomography helps assess the extent and distribution of emphysema, estimated either by visual scanning or which analysis of the distribution of lung density. Indications for obtaining computer tomography in patients with chronic obstructive pulmonary disease include evaluation for lung volume reduction procedures suspicious of coexisting or complicating disorders that are not clearly evident or excluded by chest X-ray, suspicion of lung cancer, and screening for lung cancer. Enlargement of the pulmonary artery diameter greater than ascending aorta diameter suggests pulmonary hypertension. Adjunctive tests. Alpha-1 antitrypsin levels should be measured in patients less than 50 years old with symptomatic COPD and in non-smokers of any age with COPD to detect alpha-1 antitrypsin deficiency. Other indications of possible alpha-1 antitrypsin deficiency include a family history of premature COPD or unexplained liver disease, lower lobe distribution of emphysema and COPD associated with antineutrophil
antineutrophil cytoplasmic antibody.
So NCA, yeah, ANCA, NCA positive vasculates. If levels of alpha-1 antitrypsin are low, the diagnosis should be confirmed by genetic testing to establish the alpha-1 antitrypsin phenotype. ECG, often done to exclude cardiac causes of dyspnea, typically shows diffusely low QRS voltage with a ventricle heart axis caused by lung hyperinflation and increased P-wave voltage of rightwards shifts on the P-wave vector caused by right atrial enlargement in patients with advanced emphysema. Findings of right ventricular hypertrophy include R or R1 wave as telas or taller than S wave in lead V1, right bundle branch block, and R wave similar than S wave in lead V6, right axis deviation more than 110% without right bundle branch block, or some combination of this. Multifocal arterial tachycardia, atrial tachycardia. An arrhythmia that can accompany COPD manifests as a tachyarrhythmia with polymorphic P waves and variable PR intervals, so multifocal. Echocardiography is occasionally used for assessing right ventricle function and pulmonary hypertension, although air therapy makes it technically difficult in patients with COPD. Echocardiography is most often indicated when coexistent left ventricular or valvular heart disease is suspected. Hemoglobin or hematocrit are of little diagnosis value in the evaluation of COPD, but may show erythrocytemia.
Erythrocythemia.
Yeah. Hematocrit more than 48% in the patients has chronic hypoxemia. Patients with anemia, for reasons other than COPD, have disproportionately severe dyspnea. The differential while blood cell count may be helpful. A growing body of evidence indicates that eosinophilia predicts response to inhaled corticosteroids. Serum electrolytes are of little value but may show an elevated bicarbonate level if patients have chronic hypercapnia. Venous blood gases are useful for diagnosis of acute or chronic hypercapnia. Evaluation of exacerbations. Patients with acute exacerbations usually have combinations of increased cough, sputum, dyspnea, and work of breathing, as well as low oxygen saturation on pulse oximetry, diaphoresis, tachycardia, anxiety, and cyanosis. Patients with exacerbations accompanied by retention of carbon dioxide may be lethargic or somnolent, a very different appearance. All patients requiring hospitalization for an acute exacerbation should undergo testing to qualify hypoxemia and hypercapnia. Hypercapnia may exist without hypoxemia. Findings of partial pressure of oxygen less than 50 millimeter hydrargyrum or partial pressure CO2 more than 50 millimeter hydrargyrum or partial pressure of carbon dioxide in venous blood pressure more than 55 millimeter hydrargyrum in patients with respiratory acidemia define acute respiratory failure. However, some patients chronically manifest such levels of partial pressure oxygen and CO2 and the absence of acute respiratory failure. A chest X-ray is often done to check for pneumonia or pneumothorax, very rarely among patients receiving chronic systemic corticosteroids. Infiltrates may represent Aspergillus pneumonia. Yellow or green sputum is a reliable indicator of neutrophils in the sputum and suggests bacterial colonization or infection. Neutrophils. Culture is usually done in hospitalized patients but is not usually necessary in outpatients. In samples from outpatients, gram strain usually shows neutrophils with a mixture of organisms, often gram-positive diplococci, Streptococcus pneumonia, gram-negative bacilli, Haemophilus influenza, or both. Other or pharyngeal commensal organisms such as Moraxella, Branhamella cataralis, Moraxella cataralis occasionally cause exacerbations. In hospitalized patients, cultures may show resistant gram-negative organisms, for example, Pseudomonas or rarely Staphylococcus. During influenza season, a rapid influenza test with guide treatment with neuraminidase inhibitors and a respiratory viral panel for respiratory syncytial virus,
syncytial virus,
RSV, rhinovirus and rhinovirus, and the metapneumovirus may allow tailoring of antimicrobial therapy. About prognosis of COPD. Severity of airflow obstruction predicts survival in patients with COPD. The mortality rate in patients with FEV1 more than 50% of predicted is slightly greater than that one of general population. If the FEV1 is 0.75 to 1.25 liter, 5-year survival is about 40 to 60%. If less than 0.75 liters, about 30 to 40%. More accurate prediction of risk of death is possibly by simultaneously measuring body mass index, the degree of airflow obstruction, which is the FEV1, dyspnea, which is measured using the modified British Medical Research Council, MMRC questionnaire, and excessive capacity, which measured is with 6-minute walk test. This is bold text. BOD index, body mass index, B. O is a degree of airflow obstruction, which is FEV1, and D is dyspnea, and E, so exercise capacity, so BOD index. Also, older age, heart disease, anemia, resting tachycardia, hypercapnia, and hypoxemia decrease survival, whereas a significant response to bronchodilators predicts improved survival. Risk factors for death in patients with acute exacerbations requiring hospitalization include older age, higher partial pressure of CO2, and use of maintenance oral corticosteroids. Patients at high risk of imminent death with progressive unexplained weight loss or severe functional decline, for example, those who experience dyspnea with self-care, such as dressing, bathing, or eating. Mortality in COPD may result from intercurrent illnesses rather than from progression of the underlying disorder in patients who have stopped smoking. Death is generally caused by acute respiratory failure, pneumonia, lung cancer, heart disease, or pulmonary embolism. So about treatment of COPD. No question about smoking cessation. Of course, smoking cessation. Inhaled bronchodilators, corticosteroids, or both. Supportive care, for example, oxygen therapy, pulmonary rehabilitation. COPD management involves treatment of chronic stable disease and prevention and treatment of exacerbations. Treatment of cor pulmonale, a common complication of long-standing severe COPD, will be discussed elsewhere. Smoking cessation is critical in treatment, primordial in treatment of COPD. Treatment of chronic stable COPD aims to prevent exacerbations and improve lung and physical function. Relieve symptoms rapidly with primarily short-acting beta-adrenergic drugs and decrease exacerbations with inhaled corticosteroids, long-acting beta-adrenergic drugs, long-acting anticholinergic drugs, or a combination. Why not? Pulmonary rehabilitation includes structured and supervised exercise training, nutrition counseling, and self-management education. Oxygen therapy is indicated for selected patients. Treatment of exacerbations ensures adequate oxygenation and near normal blood pH, reverses airway obstruction, and treats any cause. So about key points. Cigarette smoking in susceptible people is the major cause of chronic obstructive pulmonary disease in the developed world. Developed, not developed, doesn't matter. Stop smoking. Point. Diagnose COPD and differentiate it from disorders that have similar characteristics, for example, asthma, heart failure, primarily by routine clinical information such as symptoms, particularly time course, age at onset, risk factors, and results of routine tests. For example, chest X-ray, pulmonary function tests. Reductions of FEV1, FVC, and the ratio of FEV1 FVC are characteristic findings. Categorize patients based on symptoms and exacerbation risk into one of 4 groups and use that category to guide drug treatment. Relieve symptoms rapidly with primarily short-acting beta-adrenergic drugs and decreased exacerbations with inhaled corticosteroids, long-acting beta-adrenergic drugs, long-acting anticholinergic drugs, or a combination. Encourage smoking cessation using multiple interventions. So that's all concerning chronic obstructive pulmonary disease. Thanks for your attention. Please don't forget to make your donations. Due to our donates, we exist. So make your donations. Be so kind. And don't forget to follow and subscribe us in YouTube channel. Or I don't know where. If you find this in podcast, so subscribe this podcast. If you find this in YouTube, so subscribe and follow, not just subscribe. Yes, and put the ring on to be in touch with all news from Dr. Y. So goodbye and God bless you.